right? That's fine. Now, in Takayasu arthritis, what happens? There's a little bit of atherosclerosis in these openings, like that, okay? There's an atherosclerosis in these openings. Now, when that atherosclerosis are there at the opening, the blood flow that enter will be reduced slowly. They won't be able to go faster, right? Now, think about it. How do we feel pulse on a patient, folks? What does that pulse mean? Every time you feel a pulse, that's a reflection of the heartbeat, isn't it, folks? Right? So how do you feel it here? Because every time when the heart beats, the blood flow reflection comes in this hand. That's why we feel the pulse. Now, if you have an obstruction of the blood vessel opening, the blood is coming slowly, the reflection is almost blocked. Is that clear, folks? The reflection is blocked. So when the patient comes, I'm going to feel the pulse. I cannot. I will never be able to feel the pulse because that heartbeat is not transmitted. Is that crystal clear, folks? Because of that, this disease is also called pulseless disease. You see that here. Now, is it truly pulseless? No, they have a blood flow. I know there is another disease that true pulseless. True pulseless means your heart is not working, folks. Is that clear, folks? Okay, so this is pulseless because we cannot feel the pulse. Is the blood coming to the hand? Yes, it is coming, but they are slow, but we cannot feel it, okay? Weak upper extremity pulse, that's the idea, folks, okay? Now, patient comes with different symptoms, but that the pulseless is the key here. They also have granulomatous thickening, narrowing of the aortic arch, and proximal great vessels and stuff. Steroid is a treatment. Is everybody clear with that? Okay. Now, that's very important. Okay. So there's a true pulseless. There's a medical condition called asystole. Asystole, that means your heart completely stopped. It's not beating at all. And that time, you would not feel the pulse. That's a true pulseless disease. Is everybody clear, folks? All right. That's the cancer, folks. Okay. Now, let's take a look at the next one. I'm going to talk about Buerger's disease. Okay. Now, this disease has another name. You see the word? Thromboangiitis obliterans. That means the blood vessel that goes to the tip of the fingers. Tiny blood vessel that goes to the tip of the fingers is completely blocked. So it's 100% obstruction. We could only say 100% obstruction when we call the word thromboangiitis obliterans. Thromboangi means blood vessel. Thrombus means basically there's a thrombus in the blood vessel fully obliterating. Is that clear, folks? If we have a thromboangiitis obliterans, 100% blockage of the tiny blood vessel that goes to the fingers. So do you think the tip of the fingers will get blood flow? No. So they go through ischemia and necrosis and gangrene. That's the idea here, folks, okay? Now you could see that. The minute I say this disease, you should think of heavy tobacco smoking. That's the number one reason, folks, okay? And males, and because we know smoking creates atherosclerosis. Is that clear, folks? So that's the idea. Intermittent claudication may lead to gangrene. Auto amputation of digits. What does auto amputation mean? Like basically, let me show you a picture. That's auto amputation. Look at these toes. Those toes, if you were to go closer to it and you pull it, it will come off. It's basically like that, okay? It's completely dead. All right. Now, it's the number one treatment for that is smoking cessation. They love to ask us on the step one. When it comes to Buerger's disease, the treatment is smoking cessation, folks, okay? Now, sometimes they say the Raynaud's phenomena is present. Raynaud's phenomena means your blood vessel, smooth muscle is constricting. The distal piece of the blood vessel is not getting oxygen. Same thing is happening in this disease when the blood vessel is blocked, okay? So the same idea. So that's Buerger's disease. Is everybody clear, folks? Always remember, smoking cessation is the treatment for that, okay? Next, another super high yield disease. Kawasaki disease, folks, okay? Now, when we talk about Kawasaki disease, what is the problem? It's in young kids, less than 4, They come with bilateral conjunctivitis, some rash, adenopathy, strawberry tongue, and food changes and all these things. That's fine. There are two types of questions that comes in Kawasaki disease. What is the actual pathology in Kawasaki disease? The actual pathology is coronary artery aneurysms. These kids will develop coronary artery aneurysms. Okay. In Kawasaki disease, they develop coronary artery aneurysms. So if I ask you the pathology of Kawasaki, you're going to simply say coronary artery aneurysms. Is that clear, folks? Now, these kids, you need to give them aspirin even though they are less than 4-year-old. This is the only exception where you can give aspirin to a younger kid. Does that make sense, folks? Because we do not give aspirin to kids because it causes Ray's syndrome, which is a fatty liver. But this disease is so dangerous that no matter what, you have to give aspirin. It's better to have Ray's syndrome than getting complication of Kawasaki disease. Now, if I ask you the cause of death, this was on the exam, okay? Cause of death in Kawasaki. Type it up. What is the cause of death in Kawasaki? If I don't give aspirin, let's say they will die, but I want to know the cause of death. I want a diagnosis, exact diagnosis. How would you, if you are a forensic pathologist, how would you write the cause of death? Coronary artery aneurysm is the pathology. Okay, it's a pathology, that's not the cause of death. You guys are not thinking. Let's say I'm driving, right? I'm going in a car. I get into a really bad accident and I'm bleeding excessively and I'm dying. So what's the cause of my death? Is it car accident or is the cause of death is hemorrhage? You're going to write on the document, the cause of death is hemorrhage. I died because of excessive bleeding. If somebody could have prevented that bleeding, I wouldn't have died. Does that make sense, folks? But if I ask what's the cause of hemorrhage, then you say car accident. Is that crystal clear, folks? Because not everybody gets into car accident and dies. Car accident is the cause, etiology, but the bleeding is the death. In that case, tell me what's the cause of death. What's the pathology? Coronary artery aneurysm, right? If you have a coronary artery aneurysm, it enlarges and ruptures. What happens next? Everybody's typing aneurysm rupture. I get it. But you can't write it aneurysm rupture. That's not even a terminology. When the aneurysm rupture happens, what happens next? Where would that ruptured blood will go? Think, folks. If the coronary artery ruptures, where would the blood goes? Really, Abby? Finally, the answers are coming. Guys, if your coronary artery ruptures, where would that blood go? In the pericardial cavity. So if you have a blood in the pericardial cavity, what do we call that? Cardiac tamponade. So cause of death in Kawasaki disease is cardiac tamponade. This was on step 1 exam. Option A, coronary aneurysm. Option B, cardiac tamponade. Everybody were picking coronary aneurysm. See, coronary aneurysm is the pathology. Not everybody who gets coronary aneurysm will die. Only those who rupture and goes and causes cardiac tamponade are the one who dies. So the cause of death in Kawasaki disease is cardiac tamponade. So clear, folks? I just want you to start thinking. Okay, that's why I didn't want to give you the answer right away. But that's a cause of death. See, it says thrombosis, rupture can cause death. Well, rupture can't just cause death. The rupture has to do something. It goes and accumulates in the pericardial cavity. So everybody clear, folks? So that's why giving aspirin and immunoglobulin prevent that rupture. So they'll never get into pericardial tamponade. Because remember, if they get cardiac tamponade, in this case, you have few minutes. Okay, so that's Kawasaki disease. Is everybody clear? Okay. If you Google what's the cause of death of Kawasaki, it comes as MI on Google. But that's the reason they are saying is because when you have a cardiac tamponade and the blood vessel ruptures, you are not getting any oxygen to the myocardial tissue. But that's not because of they die. They die of a cardiac tamponade because that will develop so fast before you even get into hypoxia. Is that clear, folks? So cardiac tamponade. Okay, very good. Now, next, polyarthritis nodosa. I would say it's like a not really high yield, but you should know that. It's overused. This is very specific disease. It involves all the system in the human body except lungs. You could see typically involve renal, visceral vessel, everything, but not pulmonary arteries. So pulmonary arteries are never involved. So that's like a buzzword on the exam. When you read it and they will say pulmonary arteries are intact. So the minute you see that, you should know it's a polyarthritis nodosa. It is a transmural inflammation with fibrinoid necrosis. So we studied on the first day, fibrinoid necrosis only happens in the blood vessels. So it happens there, different stages. Okay. Now, they could even get microaneurysm in the renal artery, spasm, all these things. Symptoms, don't memorize it because symptom will be according to the system. Whatever the system involved, that system will give you symptoms. For example, if you have blood vessel to the GI, then you have abdominal pain and melena. So like that, folks, okay? Now, the only interesting thing, 30% of these patients are hepatitis B positive, and also you want to write it down C. UWorld has a question, but they talk about C, not B. Okay, so these patients are hepatitis B and C. Okay, treatment, steroid and cyclophosphamide. What is the side effect of cyclophosphamide or complication? And how do you prevent that? Hemorrhagic cystitis and Mesna is what we give, okay? So that's polyarthritis nodosa, folks. Now, in this page so far, whatever I highlighted, you cannot miss it, okay? Now, next section, there's another disease called Behçet syndrome. It happens, increased incident in people of Turkish and Eastern Mediterranean. Basically, this is an ulcer, okay? They have ulcer, genital ulcerations, uveitis, erythema nodosum. It is caused by HSV or parvovirus, folks, okay? It's a viral infection. The flare-up can last all the way to 4 weeks. Very low yield, but you should know that. Immunocomplex vasculitis. And the next one, cutaneous small vessel vasculitis. This is basically occurs 7 to 10 days after certain medication like penicillin, cephalosporins, any of those medications that causes it. Sometimes some infections, folks, okay? I wouldn't worry about this disease. Now, let's go here. In this page, let me first highlight the topics we need to learn. These two are considered the most important, folks. Okay, now let's do that first. What's another name for granulomatosis with polyangiitis? Wegener. Remember that, folks? So Wegener causes upper respiratory and lower respiratory, whereas good pasture, we differentiate, it's only lower respiratory, no upper respiratory, okay? So that's the sheets right there. So you guys already know, and then they also have renal hematuria and red cell cast. So if you see that, we talked about it, focal necrotizing vasculitis, and then we also saw the question that P-ANCA and C-ANCA against neutrophil, isn't it, folks? So that's, remember that. Again, treatment, steroid and cyclophosphamide. It's interesting, pretty much all the blood vessel disease, you either treat with steroid or cyclophosphamide, nothing else, folks, okay? So that's Wegener. This will be also very important. Immunoglobulin A vasculitis. It used to be called Henoch-Schönlein purpura. You have to know this, folks. Okay. Now, it tells you in the exam, it's always a kid that just recovered from upper respiratory infection. Okay, upper respiratory infection, and they'll give you 3 things: skin rash, abdominal pain, and arthralgia. Look at this, joint pain, abdominal pain, skin rash, that's it. And usually this is that rash purpura. Okay, they're showing it in the picture and they give that all three things, folks, you cannot forget. Again, joint pain, abdominal pain, and you have the rash, all those three things. Second, vasculitis secondary into IgA complex. Remember, we studied an IgA nephropathy, right? IgA nephropathy is associated with this. There you go. The thing is supportive care or possibly steroid, nothing else you could do for this disease, folks. Next, microscopic polyangiitis. So this is like a milder version of Wegener. Milder, or I would say precursor, that's probably the better word. Okay. Now, it's a necrotizing vasculitis commonly involving lung, kidney, skin, everything. They have a glomerulonephritis, purpura. Presentation is similar to granulomatosis with polyangiitis, but no upper respiratory involvement. So they are like almost Goodpasture syndrome. Is that clear, folks? So the difference between microscopic polyangiitis and Wegener, this one has no upper respiratory involvement, okay? It's important. Other than that, they would have pretty much everything, folks. Okay. Now you could ask me, how do I differentiate this from Goodpasture? Because Goodpasture also lower respiratory tract and the kidney. Well, they don't have P ANCA or C ANCA. Is that clear, folks? This one has it. Okay. So that's that. Now, the first one, eosinophilic granulomatosis with polyangiitis, we used to call that Churg-Strauss syndrome. It's basically an allergic situation. Think in that way, folks, okay? There is more IgE and eosinophils, and they would have all those allergic symptoms, asthma, sinusitis, all these things, folks, okay? That's a eosinophilic granulomatosis with polyangiitis. I haven't seen questions in a long time, so I wouldn't worry about that. But these two are considered high yield. And last one here, mixed cryoglobulinemia. It's often due to viral infections, especially HCV. It's a triad of purpura, arthralgia, and peripheral neuropathy, folks, okay? So just remember that. Now, these are called blood vessel disorders. Now, all those diseases that I highlighted, you cannot miss it, okay? I can certainly say you would have a question in giant cell arthritis and Kawasaki, like they always ask, because these are two high-yield topics. So that concludes blood vessel. Let's go to neuromuscular junction. Now, these two diseases again is important, but look at the word neuromuscular junction. So what does that mean? It is a disease that happening between the nerve and muscle where they meet, the connection, folks, okay? Now let's kind of learn a little bit here. So let's say, so this is the postsynaptic, okay? This is presynaptic, pre, and this is post. Yeah. Now, to give an example, we did study this on the day one. Postsynaptic cleft. This is a postsynaptic cleft that has receptors. So I'm just going to make an example. These are receptors where the neurotransmitters from here, they released, they come and bind and get the activity. Is everybody clear, folks? Now, so let's say these are acetylcholine, okay? Acetylcholine comes and binds to muscarinic receptor or any of those receptors, right? So that's that. Now, if you remember, when do you exactly release the acetylcholine come out? When something comes inside here, right? What is that? Calcium influx. Remember that, folks? So in the presynaptic channel, calcium has to come in, and once calcium comes in, acetylcholine will be released. That acetylcholine will go and bind to the receptors of the postsynaptic. Is everybody clear, folks? Are you guys following me so far? All right. Now, the first disease we're going to study, there is an antibody against this calcium channel. There is an antibody. So how do I describe that? Antibody against presynaptic calcium channel. Is that clear, folks? Now, once that antibody blocks this, no calcium coming in. So can you release acetylcholine? No. That is called Lombard-Eaton myasthenic syndrome, folks. Okay, Lombard-Eaton myasthenic syndrome. It's not common, but you could see that. Autoantibodies to presynaptic calcium channel. In the exam, sometimes they put both options, presynaptic calcium, postsynaptic calcium. Technically, there is no postsynaptic calcium. They're just playing with the word. So always presynaptic, folks. Don't forget that. So because of that, decreased acetylcholine release. Okay. Now, these people, proximal muscle weakness, autonomic symptom and stuff, right? Improve with muscle use. So what does that mean? They feel better at the end of the day. Feel better at the end of the day. Type it up, a disease we studied yesterday that they feel better at the end of the day. Rheumatoid arthritis. I kind of keep rheumatoid and lumbar together in my brain because they both get better as you use. Is that clear, folks? Rheumatoid and Lombard-Eaton, they both feel better as they use more and more, folks. Clear? Okay. Now, number one reason for myasthenic, the Lombard-Eaton syndrome, small cell lung cancer. So that's why they say it is uncommon, because whoever has this technically has a lung cancer. Is that clear, folks? So lung cancer is the one that causes, right? So to recall lung cancer, small cell lung cancer, I'm just writing it has nothing to do with this disease. They have ectopic secretion of ACTH, ADH, erythropoietin, and this autoantibody to presynaptic calcium channel. All these four things are outcome of small cell lung cancer. Is everybody clear, folks? I'm just reviewing small cell lung cancer, okay? All those will be released as an ectopic. 3 hormones you cannot forget, okay? So if I ask you what's the treatment, you have to treat the lung cancer. That's the only way patient will get, okay? So that is Lombard-Eaton syndrome. Anybody has any question? No. Now, the second disease we're going to talk about is the antibody actually coming and binding to postsynaptic receptors. You see, they bind to this receptor in the postsynaptic. Now, once they bind and the receptor, they're kind of blocking this receptor. So no matter if acetylcholine come, they cannot bind to it. Is that crystal clear, folks? That is called myasthenia gravis. That's the most common neuromuscular junction disorder. Highlight autoantibodies to postsynaptic acetylcholine receptor. See here, folks, they have a better picture than what I draw. I don't know why I draw. Now you could see that here. The antibodies are coming and blocking. Once this antibody comes and block, this acetylcholine cannot go and bind to their own receptor to get a response. Is everybody clear, folks? So this antibody, I could almost think like an acetylcholine antagonist. Does that make sense, folks? So they're binding in there, folks, okay? So that's presynaptic, okay? Now, let's take a look. Patient comes with fatigue, ptosis, diplopia, proximal muscle weakness, and everything. I'm going to highlight this word. Worsens with muscle use. So the more they use, the bad it is. So I connect this with osteoarthritis. So osteoarthritis and myasthenia gravis get worse as you use, whereas rheumatoid arthritis and Lombard-Eaton gets better with as we use. Is everybody clear, folks? Yeah, it's just easy to keep in there. Now, one of the most common association, whenever people have myasthenia gravis, they tend to have thymoma. Okay, they tend to have thymoma, folks, okay? If you want to see if the patient has a thymoma or not, what type of x-ray would you order? Type it up. You can't tell chest x-ray. I want more specific. Do you do anterior, posterior, or do you do lateral x-ray? I mean, of course, when you order, you're going to order both, okay? It's in the same place you turn, but it's more visible during lateral, because only in the lateral you could see the anterior mediastinum. Does that make sense, folks? So that's the idea, okay? So it's in the anterior mediastinum, so we order that. Now, the treatment for this, if you see here, now the antibodies are sitting here, right? The only way to kick those antibodies is to increase the acetylcholine in that cleft. So we kind of have to accumulate to increase the gradient. For that, what we're going to do, we're going to block the enzyme that causes acetylcholine esterase. Okay, now you could see that. So which means we do not want this enzyme to destroy acetylcholine as they come in. So what's a normal function, folks? Like if you see acetylcholine comes after they are done with their function, the enzyme here will break down the acetylcholine. Does that make sense, folks? But if you inhibit that enzyme, your acetylcholine availability is longer. That availability will kick the antibody away from the receptors because your gradient is higher. Higher concentration of acetylcholine will kick them out, okay? So that's why we give pyridostigmine for treatment. And it's the same medication or same process we call to test it, and then we treat it. Is everybody clear, folks? Okay, so the key things where people go wrong is this word. I'm going to highlight that. One is presynaptic, another one is postsynaptic, okay? So that's very important, folks. Like you could see that in Etanercept, the antibody is right here, the presynaptic cleft. That's a presynaptic, that's postsynaptic. So that take care of your neuromuscular junction disease. Is everybody clear? Okay. All right. Now next, in an extreme cold winter, when it's minus, if you go outside, after a few minutes, you get pain in the tip of the fingers, isn't it, folks? What's the mechanism behind? When you are exposed to cold, your body need to be protected from the cold. For that, they need to preserve the heat inside. So what they do, the body causes smooth muscle contraction of the blood vessels. So basically it's vasospasm. Is that clear, folks? That vasospasm trying to do to protect you is the one that gives you the pain. That's what basically Raynaud's phenomena is, okay? So Raynaud's phenomena is decreased blood flow to the skin due to vasospasm in response to cold. Now, some people, even with stress, they get it in the summer. So you don't have to necessarily have a cold, even a stress. So technically, anything that causes vasospasm will give you that effect. Is everybody clear, folks? Okay. Now, color change from white ischemia to blue hypoxia. You could see that picture here. Okay. Now, when people develop this vasospasm, and if you don't know what's the reason, we call it Raynaud's disease primary. But if there is an underlying condition, then we call it Raynaud's syndrome. Okay. Raynaud's disease is when we don't know what is happening, and then we have Raynaud's syndrome. Okay, that's the idea. And then if you don't treat it, what will happen? Hypoxia, gangrene, then it becomes an ulceration. Is that clear, folks? That's the idea. How do you treat? Calcium channel blocker. We studied so far 3 vasospasm diseases that causes hypoxia, right? One is diffuse esophageal spasm. Second, Prinzmetal angina, and now we have Raynaud's phenomena. All 3 of them give the same pain, different location, and the treatment is calcium channel blocker for all 3 of them. Is that clear, folks? What is the EKG finding in Prinzmetal angina? Type it up. What do you see on EKG? It's a transient ST elevation. Okay, it's a temporary, right? Because remember, when you have a Prinzmetal angina, you have a temporary ST elevation, right? When the vasospasm happens. Is that clear, folks? When the vasospasm happens.
Sorry, one question. So we will see ST elevation in this patient too?
No, I'm just asking about the Prinzmetal angina because this is happening in the hand, right?
Yeah.
So my question was what happens in Prinzmetal angina?
No, what I mean, like, because this also has vasospasm, so will we see any type of elevations or anything in it?
No, because the EKG measures the electrical activity of the heart, not your hand. Okay.
Okay, this is just gonna be in the hand, nothing else, right?
No,
That's what I'm kind of confused at.
no, this is the vasospasm. Okay. So that's Raynaud's phenomenon. Now let's go here. Next, scleroderma. Scleroderma, it's a fancy word. Just say it's a fibrosis. Look at this person. Her skin looks so clean and nice and waxy looking, right? Her face is full of fibrosis. When you have a fibrosis, it looks nice, but they cannot even smile properly because there is no elasticity. Right? They cannot look at that. There's not even a wrinkle. Does that make sense, folks? So what's happening in her face? The face is becoming full of fibrosis. Is that clear, folks? So no stretch, nothing, no elasticity. Okay, that's that. That's how Kim Kardashian will look in 20 years. I don't know, just. All right, that's scleroderma, folks, okay. Now, if you see, that's a systemic sclerosis, folks, okay. Now, when it comes to that, it's simply a commonly sclerosis of the skin manifesting as a puffy, taut skin and without wrinkles. That's all it is. Now, when it comes to that scleroderma, we divide it into two. Diffuse scleroderma and limited scleroderma. There's only two types, okay. Now, when it comes to diffuse, it's widespread skin involvement, rapid progression, early visceral involvement, okay? And there's these antibodies, anti-SL70, which is also called anti-DNA topoisomerase 1 antibody, and anti-RNA polymerase. You have no choice other than memorizing that. It needs to be scleroderma. It's only limited to skin involvement, folks, okay? Fingers and face, also with CREST syndrome, they're associated with CREST syndrome. That's the two type. I don't think they will ask you a question on this, but you should know what is scleroderma. That is a fibrosis, part of your CREST syndrome, folks, okay? So that finishes all the connective tissue diseases. Is everybody clear, folks? Okay. Now, we need to go back to bone tumor that we skipped yesterday. It's part of the bone, but I still want to make sure that we get this, okay, this page. There's a 2-page, but at the end of the day, we need to remember 3 cancers of the bone. Now, this is the best way to see that. Don't look at the name of the disease. If you take a bone, each bone has 3 different names anatomically. The middle part of the bone is called diaphysis. Diaphysis. Is that clear, folks? It's diaphysis. That's the middle part of the bone, okay? Then the edge, it's called epiphysis. And right next to edge, in the middle, we could call metaphysis. So epiphysis, metaphysis, diaphysis. You need to know that, okay? So that's number 1. Second, what we need to learn, we need to know an example of malignant tumor of each of these locations. Is that crystal clear, folks? Now let's start with first giant cell tumor here, folks, okay? Giant cell tumor. Giant cell tumor happens in 20 to 40 in the middle age. It is a disease of bone tumor that happens in epiphysis of the bone. So giant cell tumor is an example for epiphysis, folks, okay? This is important, okay? The reason I'm telling is it looks so easy today, but in 1 month, you would know what is giant cell tumor, but you'll be confused whether it's epiphysis or diaphysis, okay? It happens to me. If it happens to me, it can happen to anybody because it's a normal behavior, folks, okay? So let's make a nice chart. So let's say epiphysis, okay? Epiphysis, giant cell tumor. Okay, giant cell tumor, locally aggressive benign tumor, and these cancer cells express RANKL. What does RANKL do? RANKL binds to osteoclast, isn't it, folks? It goes to osteoclast. You could see that giant cell osteoclast, so bubble appearance on X-ray. So I'm going to write they express RANKL. And on the X-ray, soap bubble. If you know this much, you're not going to miss this question. So you need to know it's a giant cell tumor that happens in epiphysis, Rankel expression, X-ray shows soap bubble, folks. That's for epiphysis. Okay. Everybody clear with the giant cell? All right. Let's move to the next one. Osteosarcoma or osteogenic sarcoma, it doesn't matter, osteosarcoma. What we need to know, there's a little problem here, the way it says, this is the second most common bone cancer. So you know what's my question now? What's the number one bone cancer? I talked to you guys before this somewhere else. This is wrong. It accounts for 20% of the primary bone cancer. So the 80% of the time, this is secondary. So what's the number one bone cancer we studied? Come on, folks. That's a big disease. It's one of the most important disease. That cancer has anemia too. Slowly coming out. Anemia. I can't give more information. Maybe I'll give you M-spike. It's multiple myeloma. Multiple myeloma is the number one bone cancer. Is that clear, folks? That's number one, and this is number two. So write it down somewhere here. First is multiple myeloma. Multiple myeloma, what type of immunoglobulin is involved in that? IgM and? No, it's IgG and IgA. Okay. IgG and IgA, folks, okay? And these are the light chain that we come into kidney. Once that enter the kidney, those light chain get a special name, Bence-Jones protein. Does that make sense, folks? All right. So this is the second most common bone cancer, which we call osteosarcoma. Look at this word. It happens in metaphysis. So we're going to go right. Second example. Metaphysis. Osteosarcoma. Okay. So the example for metaphysis is osteosarcoma. It's painful enlarging mass. The key word for this, Codman triangle, or it's the same thing known as sunburst pattern. Okay, so I'm going to say Codman triangle. Which is a sunburst pattern. I'll explain what it is. Now, if you see, look at this picture here, folks. Do you see a triangle? I'm going to create a triangle. Do you see that triangle elevation in there? That is called Codman triangle. So that means there's a little elevation on the bone, right? So that's what they are trying to tell. That's a Codman triangle. Sometimes it looks like a sunburst pattern also. Do you see that, folks? That's a Codman triangle and a sunburst pattern, okay? So when you see that, that's a buzzword for osteosarcoma. Aggressive primary usually responds to treatment, chemo and stuff. That's the key, folks, okay? That's your osteosarcoma. Are we clear so far? So we studied one for epiphysis, giant cell tumor. Then we have metaphysis, osteosarcoma. The third one we need to learn, diaphysis, right? We need to learn diaphysis. The example we're going to learn for diaphysis is going to be Ewing sarcoma. Ewing sarcoma. It happens in kids. These are anaplastic tumor, which means pretty bad when it comes. Ewing sarcoma. Aggressive with early spread. Second thing you need to know, onion skin appearance. Okay, onion skin appearance on X-ray. So I'm going to say Ewing sarcoma, onion skin. Okay, funny and skin appearance. And this is a diaphysis, folks. Okay. Now you see these three chart, if you can, I don't think they have a space, but that needs to be in your fingertip for the exam, folks. Okay. Now it's easy to make a chart and stick it on a sticky note on the same page. So you won't have any problem. One for epiphysis, one for metaphysis, and one for diaphysis. Okay. So it's careful. It becomes very easy to confuse, folks. Okay. So those are the three malignant tumor we're going to worry about. Everything else is benign tumor. So there's no need to even worry about that, folks. Okay. So that's that. Okay. So that concluded the bone tumors. Now let's go back to basic anatomy, folks. Okay. Let's start with, I'm going to start with childhood musculoskeletal conditions, folks. Okay. The three diseases I highlight is very important for the step one. We're going to go through all of them, but those three are the most important in this picture. Now let's start with the first one. The first one is called radial head subluxation, which also called nursemaid elbow, folks. Okay. Now look at this picture. That picture explains the pathology. That's an ulnar bone, and this is a radius bone. This is what we call annular ligament. Annular. Okay, that means it goes around. Okay, folks. Now, in a healthy person, normal person, this radius bone should be here. This should be here, touching that condyle, folks. Okay, it should be up. Now, what do you see? The bone has descended. Somebody pulled the bone down. Does that make sense, folks? How many times have you hold a little kids with holding the hands? I do it all the time. It's easy, right? We hold them. That's such a danger because what happens is this happens in kids less than 5 years, caused by a sudden pull on the arm, folks. It's like you hold the hand, and if you pull them suddenly, it can dislocate and it can come down from that ligament. No fraction, nothing. It's just a dislocation. Is everybody clear, folks? Okay, that's that. Immature annular ligament slips over the head of the radius. Injured arm held in slightly flexed and pronated, right? This is flexion and pronated. So they come to the ER like this. They won't even let you touch it. Okay, they literally come to the ER holding the hand. So what the ER physicians do, they do supination, extension, and they put it back. They could actually fix the problem right away in the ER, folks. There's no need for surgery and stuff, but that's nursemaid elbow. Is everybody clear, folks? So the two things you should be able to pick up in the question, and they could ask you what ligament is involved, that's annular ligament, or they could even ask you what bone is involved, that's radial bone. Is everybody clear, folks? All right, so that's nursemaid elbow. Next, this one. Osgood-Schlatter disease, we call that traction apophysitis, right? Now, before we talk about it, we need to know about the muscles in the thigh, quadriceps femoris. Quadriceps femoris is the biggest muscle of your lower extremity, okay? It has 4 heads, that's why it's called quads. Does that make sense, folks? Now, what is the origin and insertion of the quadriceps femoris? Origin means where it's attached and where it goes to, right? Origin is a anterior superior iliac crest of your hip, and it goes all the way to below the knee. So that means quadriceps femoris is a muscle that crosses 2 joints, hip joint and a knee joint. Is that clear, folks? Muscle has to cross a joint. That's why you need muscle. You don't need a muscle if it doesn't cross the joint because they don't have a function. Is everybody clear, folks? But this one crosses 2. So when do you use that muscle, quadriceps femoris? What function is that? Flexion and flexion of the hip, extension of the knee. Is that clear, folks? Flexion of the hip, extension of the knee. Because remember, hip, you are flexing, coming closer to your body, extension, right? So you need that muscle if you want to stand up from your chair. Agree, folks? That's the idea. So when we do squat with a heavy weight, when we go, we are training that muscle. Is that clear, folks? Now, there are people who does that frequently. Who is that? Jumping people. When you jump, you're basically getting up faster from the chair. Is that clear, folks? All right. This is an overuse injury and repetitive strain on a chronic evolution of the secondary ossification center. So what's happening? This is common in running people and jumping people. So when they do that frequently, wherever that muscle is attached, it's like a small inflammation. How does muscle works, folks, right? Muscle is attached to bone somewhere. Is that clear, folks? Now, when they pull it so much, it creates a little inflammation where the muscle is attached. Is everybody clear, folks? So that's called traction apophysitis. We look at the word, it's a traction. The more you pull, the bad it is, folks, okay? So they come with it, presents with anterior knee pain. So what do we tell them? They cannot do any of those activity for a couple of months until that inflammation heals. Is everybody clear? That's the most important, folks, okay? And if you see some jumping athletics, they will put a band in the leg, folks. They put a band around it. Why do they put a band? It's basically they're giving extra support where that muscle is being attached. Is that clear, folks? That's the idea. Now, I will talk about the band when we do upper extremity more. So this is common in jumping people, folks, okay? Now, that's a tendon, and if they continue here, that's your quadriceps femoris. That's a quadriceps femoris muscle. Is everybody clear? Anybody has any question in this disease? Okay, that's quadriceps femoris. Next, patellofemoral syndrome, folks, okay? There's the patella, you could see right there in here. Sometime overuse injury that commonly presents in young female athletes as an anterior knee pain, exacerbated by prolonged sitting or weight bearing. Other than athletics, who do we see this? Which type of professional we see this problem? People who does flooring, cancer. People who does flooring comes with this issue all the time because when they do flooring, they're on their knees for all day on the floor. Does that make sense, folks? That's why they use that special pad on the knee. So it doesn't affect, because when you are sitting on the knee, the whole pressure goes to the knee, isn't it, folks? So that's this, folks, okay? Now, that's that. Now let's go take a look at some x-rays, because unless we see that, it won't make sense. I'm just showing